Okay. So when you want, you can
Okay.
start. Okay, perfect. Yeah, magnifique.
Hello, my name is Niara Romero. I am the International Relations Coordinator here at ABRALI, the Brazilian Lymphoma and Leukemia Association. And today we're going to be talking about the acute leukemia patient's journey in Brazil. So just to give you a little bit of context, since our founding in 2002, we have helped thousands of patients across the country. Based on our values, we work to improve access to diagnosis, treatment, and quality of life for people with cancer and blood disorders. And our mission is to offer help and mobilize partners so that all people with cancer and blood diseases in Brazil have access to the best treatment. Our values include love, ethics, comprehensive care, equality, acceptance, faith, and unity. We have four pillars in our organization, which include patient support. The department is formed by professionals specialized in health to assist all patients in Brazil, clarifying their doubts regarding cancer and its treatment, and also offering psychological, legal, nutritional support, and a second medical opinion. Education and information. We use different channels to provide patients with information about blood diseases and their treatments. Knowing the disease makes them able to participate in decisions about their health. For the general population, we promote health education campaigns and with a distance education program project OncoEnsino, we also offer training to doctors and health professionals. Public policies. We work intensively in the advocacy field together with the responsible bodies to improve the promotion, humanization, and access to cancer treatment. And the purpose is to improve the outcome of treatments in Brazil. And last but not least, the research and monitoring department. The Oncology Observatory is an online and dynamic platform for monitoring public data, and it's possible to evaluate health policies and their application in society. So with surveys, with patients, health professionals, and doctors, they provide us relevant information about the journey and the therapies applied in the country. So since 2002, more than 50,000 patients and family members have been benefited gratuitously. 20,000 doctors and health professionals have already been trained through the ABRALI programs. And we have national operations via regional representatives in more than 273 reference centers in the country. So now discovering leukemia, and also talk about a little bit about the pathology. So it happens when white blood cells responsible for fighting infections in our body lose their defense function and start to reproduce in an uncontrolled way. There are more than 12 types of the disease, but the main four ones are acute myeloid, acute lymphocytic, chronic myeloid, and chronic lymphocytic. Among these types, the affected age, aggressiveness of the disease, and indicated treatments are completely different. And today we'll be looking more into the acute leukemias. So one of them is the ALL, acute lymphocytic leukemia. This is the most common type of cancer in childhood and usually appears in children and so-called young adults. ALL has a fast and aggressive development. 90% of children with the disease are cured. For adults, the survival rate is 50%, with 40% having a relapse of the disease. And according to the Brazilian Association of Hematology, Immunotherapy, and Cell Therapy, the disease has the following risk factors: being exposed to radiation and chemical substances. And although there's no evidence that it is hereditary, some family syndromes are risk factors. And the treatment is chemotherapy. Now, the AML, acute myeloid leukemia, is usually diagnosed in people over 65 years of age. Men are more affected than women. It needs treatment, and in some cases, 100% compatible allogeneic bone marrow transplantation is indicated. Again, according to the Brazilian Association of Hematology, Immunotherapy, and Cell Therapy, the disease has the following risk factors: smoking, prolonged exposure to chemicals, and genetic syndromes. And the treatment is also chemotherapy. Now, the incidence, the number of new cases of leukemia expected for Brazil is around 10,000 in 2022, being 5,920 cases in men and 4,890 in women. These values correspond to an estimated risk of 5.67 new cases per 100,000 men and 4.56 per 100,000 women. And going more into the regions, without considering non-melanoma skin tumors, leukemia in men is the 5th most frequent in the North region, the 7th in the Northeast region, the 10th in the South, and the 11th in Southeast and Central West in Brazil. And for women, it's the 6th most frequent in North and South. It occupies the 10th in the Northeast. It's the 11th in the South Central West, and the 12th most frequent in the Southeast region. Regarding to mortality, in 2017, there were 4,795 deaths from leukemia in Brazil, with a crude mortality rate of 4.75 per 100,000 men, and 4,401 deaths with a crude rate of 4.25 per 100,000 in women. So if we apply this number of deaths on top of the expected new cases of leukemia for 2022, we can calculate a fatality rate of around 40%. Now, going into the ALL patient's journey, we have a lot of data here, and the source is a qualitative research of therapeutic follow-up with 400 ALL patients in 2019. So I'm going just to touch upon the information that catch our attention. So among the 400 respondents, 32 were patients and 68% are caregivers. 53% had never heard of the disease before, which is important to know. 94% of the patients had symptoms that led to the search of a doctor, being 30% fever, excessive tiredness, 26% bone and or joint pain, 24% bruises, 16% pallor, 12% headache, 11 enlarged lymph nodes, 8% vomiting, and 7% bleeding. And after the symptoms appeared, 22% saw the doctor from a week to a month, 8% from 1 to 3 months, 7% took more than 3 months or do not remember. And they usually looked for a pediatrician at first or general practitioner. In regards to the diagnosis, 60% went through several doctors until the diagnosis was made. 49% went through several medical institutions to reach a diagnosis. 26% had an inconclusive diagnosis, and 13% experienced lack of access to specific exams. And 12% had problems getting the first treatment. So with that being said, the reasons include they waited for the treatment center to provide the medication, majority being 53%. Others paid out of their pocket. Others had to file a lawsuit, and 4% file administrative proceedings at the treatment center. Another alarming data, I believe, is that the first treatment protocol indicated 25% did not know the protocol used. And 67%, the doctor never talked about the minimal residual disease, MRD. 18% needed to change treatment because 46% had no response in the first treatment, and 37% had a very aggressive side effects. And moving to the quality of life, 52% of patients took leukemia medication for 24 months or more, and 12 from 1 year to 18 months. Now going into the AML patient's journey, it was a qualitative research of therapeutic follow-up with 78 AML patients of supplementary health, and also in 2019. 81% of the respondents are patients, and 19% are caregivers. And with that being said, 55% had never heard of the disease. Again, with the symptoms, 87% of patients had these, including excessive tiredness, bruises, fever, bleeding, pallor, petechiae, bone and or joint pain, drowsiness, headache, and constant infection. After the symptoms appeared, 35%, which is the highest number here, saw the doctor from a week to a month. Then 12% from 1 month to 3 months, 1% from 3 months to 6, or over 1 year. 18% of the respondents said they had difficulties in closing their diagnosis. Among them, 57% went through several doctors. 50% had an inconclusive or a doubtful diagnosis. 21% went through several medical institutions. 14% had difficulty scheduling an appointment with a specialist or experienced lack of access to specific exams. 10% also faced difficulties in getting the treatment, and similar to the ALL, they waited for the treatment center to provide the medication, or they paid out of their own pocket, or filed a lawsuit, or even experience inadequate structure in the hospital. And 65% also did not know the induction protocol indicated. And 68%, the doctor never talked about the minimal residual disease. 22% needed to change treatment, including 88% with a no response and 12% with very aggressive side effects. And in regards to quality of life, 62% received medication for more than 6 months, and 18% developed a mood or emotional disorder, 9% had difficulty thinking or a bad memory, 8% had the GV host disease or chronic pain, diabetes, and another 23 problems were cited with 5% or less. In conclusion of the findings of these journeys, in terms of diagnosis, in general, leukemia patients do have symptoms. About 50% of patients were unaware of the disease before diagnosis. In journeys involving the public health system, at least 1/3 of all patients interviewed took more than 1 month to complete the diagnosis. In terms of treatment, all journeys have some difficulty in carrying out the first treatment protocol indicated by the doctor. And to solve this, as mentioned, patients paid for their medication out of their own pocket, or they had to file a lawsuit. In terms of patient and family empowerment, many patients demonstrated that they did not know which medications they took during treatment. And more than 60% of patients also did not know the MRD. In terms of quality of life, about 50% of patients spent at least 1 year undergoing treatment, which can compromise quality of life. So these were the findings based on the journeys, and I think these are very important data. We also based our awareness campaigns on these numbers, right? Because we see where, in what specific area they need more information, for example, as here they did not know about this disease. So awareness campaigns come from these journeys at Abrali for all the pathologies we give support. So these are the findings, and that sums up my presentation. So thank you very much.
Okay. Thanks, Nyara. Can I ask you questions before we move on?
Yes, of course.
Easy ones. No, no worries. Because you said, for example, that like more than half of the people have never heard about the disease, but did you go into the details to know if people actually knew that leukemia was a kind of cancer? Did you ask that question as well?
I would have to check with the research department, as they did the research, right? And they had a close contact, direct contact with the patients. I believe some knew it was cancer, but others they didn't know leukemia was a cancer. Yeah.
Okay. And why do you think it's so complicated to get diagnosis?
I think it comes from our health system. The public system is SUS, which is an example for other countries, but there's still some problems, and also social problems, because there is a great inequality among the population in Brazil. So the most fortunate ones have more access, they have more information, they will go and see a doctors. Others, they're trying to live, right? They need to work. If you know, other social problems that may be, the health won't be a priority at that moment, right? So I believe there's a lack of many things. So a lack of information, lack of access. Maybe also when they go and see a doctor, as it shows in the journeys, they have to go through many doctors. Some were not able to diagnose at first, so that must probably cause some frustration. You know, there are many difficulties still, and Abrali is here to work in national coverage to give these patients not only support, but information, like a quality information, right?
Yeah. Thanks.
No problem.
Doctor, do you want to go next?
Yeah, sure.
Do you want to share your slides?
Yes, I'll go ahead and share. But I think perhaps maybe Yara will have to stop sharing. So
Maybe.
Yes, I'll stop. Let me see here.
I think it's on the top row. Yeah.
That's it.
Yeah, that's okay. we can see.
Okay. Okay, so I'm going to be talking about the experience we have here in Nigeria, looking at treating acute leukemia in low and middle income countries. I'm Dr. Yusuf Adelavo, the Executive Director of the White Cell Foundation in Nigeria. Is a non-governmental organization which I founded in 2012. Which was in 2020, sorry, which we started advocating for blood cancer patients in Nigeria. I also lecture at the university, the College of Medicine, where I'm also involved in the training of hematologists and other medical professionals. And I'm also active in practice, in hematology practice as a physician and hematologist. So the White Cell Foundation, as I said, founded in 2020. So barely about 2 years we've been on now. We have a three-pronged approach to our mission and vision, which is to improve the quality of life and survival of blood cancer patients in Nigeria. And we do this through advocacy and also by creating awareness, providing support for blood cancer patients, and also through research. Now I'm going to be discussing this, with this outline, just give an introduction about acute leukemias and how it's been, treating acute leukemias in Nigeria. We'll look at some of the challenges of treatment, and also would conclude with how we suggest to improve these and some of the things we are doing to help to improve the mode of treatment of acute leukemias in Nigeria, and I will conclude from there. So acute leukemias, as we know, is a very heterogeneous group of malignant conditions, which is characterized by defects in the maturation of the blood-forming cells, that's the hematopoietic cells. And generally, if an acute leukemia is left untreated, it could lead to death in a matter of weeks to months. And this underscores the importance of prompt diagnosis and treatment of this condition. The lack of accurate data when acute leukemia in most low and middle income countries, Nigeria inclusive, many of countries in this category actually lack very good cancer registries, so they do not have enough or accurate enough epidemiological data. So, but even despite knowing that we don't have accurate enough data, it's widely agreed that the cancer burden is actually more in the low and middle income countries, and also that they also suffer a poorer outcome compared to high income countries. So I would be discussing with you what it's like to treat acute leukemia in a low and middle income country like Nigeria. So we'll look at it in the aspect of the patient journey in Nigeria. So I've kind of grouped the challenges, and I would, as I go along, speak with what are some of the experiences we have in this part of the world, and some of the things we're grappling with and trying to find innovative solutions to them. Starting from the very outset, knowing that early identification of the signs and symptoms of leukemia is very, very important, essential in terms of being able to even start the process of having a diagnosis made and subsequently treatment. So there's a very low level of awareness and poor health-seeking behavior in most low and middle income countries, particularly Nigeria. And The importance of early education of the signs and symptoms also now relates to what the consequences may be if there's late presentation. As I did mention in the introductory slide, that this condition requires a prompt diagnosis and treatment. So lack of awareness of even knowing about some people about leukemia, and some don't know what the signs and symptoms are, and that's why some of the efforts through our foundation is to be able to increase or raise the level of awareness, particularly in the community. Part of the factors that's responsible for this is the poor access to information. There's a very high level of illiteracy in most regions of the country, and so many are in the low socioeconomic strata, and so they are more, occupied with having to source for their daily living, and so many don't even pay much attention to their health condition, and therefore they are not likely to be able to seek medical attention early enough, even when they do develop signs and symptoms that are highly suggestive of acute leukemia. Now, moving on to even away from the individual, looking at the system now. So there's an inefficient health system whereby the patient is not able to even access the treatment that they require, even having presented early or having noticed the signs and symptoms early, and even wanting to have appropriate medical treatment. For a country like Nigeria, in West Africa, we have population of over 200 million with a very huge land mass. Some settlements are even very much far from the nearest health center. Many have to travel, several kilometers or even miles to be able to get to a place that could even access more of the basic healthcare, rather than even talking of the more specialized care. Even for those that have it, there's an inadequate number of it, particularly in the cities where I'm based here in Lagos, which is the commercial capital of the country. The state alone has over 20 million population. And if you look at the number of hospitals, both the private hospital and the public hospital, compared to the population they serve, it's grossly inadequate. Many actually ill-equipped, don't have the required facilities and or expertise to be able to manage such conditions. So this is part of what leads to the delayed presentation, delayed diagnosis, and of course delayed treatments, which ultimately have an impact on the survival. Now the health system also, despite the efforts to have there being a chain of referral from the primary to the secondary and then to the tertiary health system, we still find out that the system is not so effective enough, and so there's late referral for specialist care. And even among some medical or health practitioners, many are also unaware of the signs and symptoms. Most patients may have been either not diagnosed or even misdiagnosed at some point, and because of every other thing that may be involved, they may even not even think about leukemia or even refer the patient early enough for specialist care, even if that was in their thoughts in terms of what could be the diagnosis. Now, even at the tertiary centers where the specialist care is available, still also at inadequate manpower. There are very few hematologists to treat leukemia patients or other hematologic disorders, including malignancies. With one of the challenges we have in our healthcare system here is what we refer to as brain drain, where specialists are moving in droves from low to medium income countries to high income countries because of poor remuneration, poor what they call the poor service of treatment, and also the poor employment things that they have to work with. Basically, so a number of things really affect this in this population. Now, a major challenge in the health system that have a very important impact on the healthcare is even how to even pay for health services. So a very low level of health insurance, a very low amount of people have health insurance. So there's a national health insurance which barely even covers for cancer treatment. Because there have been efforts to see how patients with cancer, not just only hematologic malignancy, will be able to have treatment or access treatment. So many patients end up having to pay out of pocket because even in the health insurance system, less than 10% of the population are registered to have a cover under the health insurance. And even in other settings in which we have managed care, which are health management organization, most people are only able to get on some medical plan by virtue of their level of employment. If their employer actually do subscribe to a form of health insurance, that's when they're able to benefit from that. Whenever they're out of work, they will not be able to access such medical treatment. So there's a whole lot in the health system and access to healthcare that has an impact in the treatment of acute leukemia in Nigeria in particular. Now, moving on to the diagnosis, and so this slide and the next slide is where I'm going to speak more on the major challenges and how it looks like or how it is in managing or treating acute leukemia in lower middle Nigeria. So there's a gross inadequacy in the diagnostic capacity. And we know that the diagnosis, investigations are quite very vital and important in acute leukemia, especially, particularly not only in diagnosis, but also the choice of treatment and also in monitoring the response to treatment of this condition. So look at the entire spectrum of the diagnostic armamentarium. Most of these are not available because the basic one, which is the cytology and the histology of the blood or the bone marrow, most hematologists are able to do that, and we're able to make some provisional diagnosis based on that. But we cannot overemphasize the importance of further studies which would help to not only confirm the diagnosis but also aid in the treatment modality that will be employed and also in monitoring the response to the treatment. So occasionally we won't have challenges in getting CSF analysis, which is useful, particularly in acute and lymphoblastic leukemia to check for CNS disease or CNS involvement. But we had challenges with this even within the during the COVID pandemic, particularly when it was at its peak. It was difficult to even get a lab that would be willing to analyze the cerebrospinal fluid in the short duration of time that is required before the sample become not viable. And so despite being a basic test, it's also still a challenge managing arrhythmias, particularly AML. Moving on to the advanced tests, most of these are not available, or even when available, they're available at a very low scale. And so we still depend largely on laboratories in other neighboring countries or even overseas to get these samples actually analyzed for the various tests, the advanced tests, like the immunophenotyping, flow cytometry, immunohistochemistry. Some of the laboratories in Nigeria do have a minimal capacity for immunohistochemistry, but there's no flow cytometry analysis available domiciled in the country. So depend on other countries to have this analyzed. Same with cytogenetic and even FISH, which is the in situ hybridization to detect some translocations associated with various types of acute myeloid and lymphoblastic leukemias. The molecular studies, which plays a very vital role in the choice of treatments, particularly for targeted therapy, is likely unavailable. Then, first, next generation sequencing is even very still far out of reach. So we barely even talk about minimal residual disease because we are not able to get the patient to do any of these molecular assays that can be used to detect minimal residual disease and the likes. So this still constitutes a major challenge in treating acute leukemia, particularly here in Nigeria, having this diagnostic inadequacies that still, very much hamper the treatment of acute leukemia in Nigeria. So as I mentioned, most of these tests, particularly the advanced ones, we usually have to ship the samples to laboratories in other countries, South Africa, we're going to have some going overseas to as far as the UK and even the US. And so all of this, having to ship the sample abroad increase the costs of, so that raises the cost of the treatment. So as I said, most patients pay out of pocket. So in addition to the cost of the test, which is expensive on its own, the added cost of shipment also further adds to it, and this further makes it quite difficult for patients to undergo the required test. And this ultimately leads to delayed diagnosis, and knowing that an acute leukemia need prompt diagnosis and treatment, this eventually does have an effect on the outcome of acute leukemias in Nigeria. So one other aspect I'd like to mention before moving on is misdiagnosis. At least in my practice, I've had referrals, from different peripheral hospitals, more in the primary and secondary health centers, and many patients have been diagnosed with other conditions have been being treated over a long period of time for a wrong diagnosis before being referred eventually when there's no response to the treatment. And so that's one of the aspects we're looking into, in that having to make a proper diagnosis. But we know that not having the required diagnostic capacity in terms of the resources, infrastructure, and the personnel still hinders this significantly. Now to the treatment itself, which is the other aspect where most of the issues are. We know that acute leukemias require not only the specific treatment, but also they require a very high level of supportive care to be able to withstand treatment, to be able to also get to address the complications or the side effects of the treatment, and thereby coming out of the treatment alive, and also being able to live a productive life afterwards. So when it comes to treatment, for the standard treatments, both for acute myeloid and acute still needs to pay out of pocket, because I said earlier, less than 10% of the population are enrolled in the National Health Insurance, or even maybe in some form of managed care, where they would have the insurance pay for their treatment. But even those that have the insurance, once they exceed the limits of their insurance, they still have to pay out of pocket. And we know how expensive it could be in treating acute leukemia. The other thing is with even the availability of advanced treatment. So aside from the standard treatment, those that may require targeted therapy, for example, in patients with ALL, with the Philadelphia chromosome, being able to be able to access the tyrosine kinase inhibitors, or even patients with AML with specific molecular markers like FLT3, and being able to be on the FLT3 inhibitors. These are medications that are not available. Some patients were able to source for the treatment abroad, but it takes time to even get the medication put into the country, following all the regulatory steps, and this usually does hamper the treatment. And acute leukemia, which there's really no time to waste in terms of treatment, because it could be fatal in weeks to months. And so having the treatment not readily available is a major challenge. So patients that don't respond to the standard treatment, having to get them on this. So most patients end up going on palliative care, and these have impact on the outcome, sure. Other targeted or advanced treatment like the IDH1 or 2 inhibitors, and also immunotherapy like blinatumomab that's used in some ALL conditions are not directly available. Now, the curative modality of treatment, which is stem cell transplantation, currently, as I speak with you, there's no stem cell transplantation program that is currently active in Nigeria. The efforts to actually start this, particularly in sickle cell disease, and so there've been some level of work done in this aspect at the center somewhere in the southern part of the country, in which one of the hematologists was able to start the program, but due to several challenges, the program had to halt even before it's really gone so far for it. So most patients, or virtually all patients, let me say, with acute leukemia that may require stem cell transplantation, quite a number of them actually falling under this category. They are not able to have the treatment done. So most patients have to travel out of the country to other countries where this is available. And of course, transplantation on its own is not a cheap treatment to have. It's quite expensive. Also putting on the added cost of travel, and stay for several weeks and months in foreign country also adds more to it. So very few patients are able to afford this. Only those that actually quite wealthy or those of the high socioeconomic strata are only the ones able to afford it, or those that are able to gather funds through crowdfunding to be able to undergo these treatments. And of course, because of the delay in even trying to get the funds and all that, these also have impacts on their survival eventually. Now, I mentioned about the supportive product, the supportive care, like blood products, particularly platelet concentrates or even apheresis platelets. Until recently, there were no apheresis platelets available in the country, but there were quite a number of blood banks and also some blood transfusion services started bringing or started using apheresis machines to be able to get apheresis platelets. And ultimately, these are also some of the efforts being put in place to eventually transit to having to do hematopoietic stem cell transplantation. Now, infection control, we know that during the treatment for acute leukemias, particularly in the intensive phase of the treatment, usually leads to quite some suppression in the immune system, and they're prone to infection. So having to get a proper setting, hospital setting, or ward setting, for infection control, it's also a challenge. Knowing that there are also some infections that are endemic in these parts of the world, including parasitic infection like malaria and the likes. And so we're going to have, in addition to the condition itself, many patients are not able to survive the critical period of the treatment where they may have succumbed to severe infection, and even getting to the level in which they may require organ support in form of either hemodialysis or even require ICU care. And this is one of the major factors that lead to the difference in the survival of acute leukemia, patient with acute leukemia in low and middle income countries compared with high income countries, because these medical services are readily available and at a very high level, but here it's really quite on the low scale, and many patients are not able to survive that period because of the lack of supportive care that they require. Now, some other challenges which I kind of put separately from the other groups is that, because many of what have been discussed or talked about also come into play in terms of there being a substantial, significant delay from the onset of symptoms to the initiation of treatment. Either they are not presenting early because they are not able to identify the signs and symptoms, or there's a delay in the healthcare system to get into where they can even get the proper diagnosis done and the treatment, or even having inadequacies or non-availability of the diagnostic requirements or diagnostic tests that needs to be done, or even when the diagnosis has been made for treatment to start, many patients by that time may have even been financially exhausted by having to pay out of pocket all through the way. So even when the diagnosis is made, they're not able to afford the treatment. And that's why organizations like our organization, the White Cell Foundation, part of what we do is to help patients, support patients with their treatment through fundraising and being able to pull funds together to ensure that particularly indigent patients that are not able to afford treatment. Try to see how to support them with their treatment in order to ensure their survival. Other challenges is the high rate of abandonment of treatment, which comes with all of this, as I've said. So particularly like ALL, for instance, it's even more common out there because of the long duration of treatment, not just only the intensive phase or the consolidation phase of the treatment, but even the maintenance phase, which usually takes up to about 2 years. So we find that patients, even after attaining remission, complete remission, you just suddenly don't even see them coming again for follow-up care or for further treatment, and only maybe later in a couple of months to see them having a relapse. And because at that time, there's very little that can be done at that time. So a high rate of abandonment is one of the challenges of treating acute leukemia in Nigeria. So lastly, I mentioned the treatment-related toxicity. So those are even able to undergo the entire treatment. We know that particularly some of the standard treatments, the line treatments still have quite a lot of treatment-related toxicity, particularly to organ function, some developing had some, cardiac toxicity or lung toxicity or other forms of, chronic or side effects of the treatment or long-term side effect of the treatment. And we know that even treatment for this treatment-related toxicity is grossly inadequate, particularly in patients that even develop kidney failures or even develop cardiac failure from this. This further adds to the already poor prognosis of this condition, and in most patients that it leads to death. So even though in the high-income countries there are efforts to see how to get to use treatment that are less toxic, and here we don't even have that luxury to be able to pick and choose what treatment to give, because the one that patient can afford, in as much as it's effective enough, I would still go with that. But many patients may need to be on any of the targeted therapy or even the immunotherapy and or proceeding to stem cell transplantation. But many a time they are unable to even get to that stage, by which that can even be often. So I would end the presentation by saying some of the things that I think would improve the treatment in low and middle income countries. Not only would this apply to Nigeria, but to other low and middle income countries. And these are some of the work we're doing in my foundation and some similar foundations to or non-governmental organizations that are also operating in these countries. Of course, awareness, as I said, one of our three-pronged approaches increase the level of awareness, because we know that if we increase the level of awareness or raise the level of awareness in the community, at least that comes from the patient's angle in terms of having to present early, and they're also getting to be aware of where they can access the right treatment that is required. Because a lot of advocacy has to go into this. We need to advocate for even creation of treatment centers, advocacy in terms of having maybe the reduction in import duties to be able to bring in some of the equipment that are required or even the medications that are required. Increasing the access to health insurance, I said less than 10%, having more people enrolled in the health insurance system and being able to access the treatment that they require is very vital and would go a long way in improving the treatment of acute leukemia in this country. Of course, generally strengthening the health system would help in making sure that the patient get the treatment or are able to access the treatment, and that avoids or reduce the delay in getting to the centers that would be able to do the diagnosis tests required and offer the treatments that needs to be given. So a lot of investments needs to be done in diagnostic areas. There are quite a number of private laboratories, even foreign laboratories, looking at that. It's a high demand for proper diagnostic facilities domiciled in Nigeria, which will reduce not only the cost of the treatment, but also reduce the delay in initiating treatment. And so a lot of investment we need to go into this because we know how expensive this diagnostic equipment and facilities can be. Then finally, increasing access to care generally, which all of this would contribute to, but more importantly, to even have more centers where, because I said we have a huge population, and so the number of healthcare facilities to take care of that population is still, there's still a lot of understaffing of even some of the established ones. And so these are some of the things that needs to be improved upon that can help to better treat acute leukemias in these countries and also ultimately improve the overall survival. So in conclusion, although the high burden of acute leukemia in these countries and the abysmal outcome of this condition, there are myriad of challenges in treating acute leukemia, at least from first-hand experience by myself, practicing in this part of the world. These are some of the challenges. That there's so many, there's really not one or two we can say is the major one. They are all affecting the treatment of these patients for them to get the required outcome. And therefore, several interventions are required to be able to address some of this, most of these challenges to help improve survival of patients with acute leukemia in these countries. Thank you very much for your attention.
Thanks a lot, Doctor. I think I'm asking a questions from your hat of a doctor. So how many patients do you see in a day when you are in the clinic?
Okay, so the hematology practice is kind of a bit combined, so we don't have separate benign and malignant hematology. So we have both patients with non-malignant conditions like sickle cell disease, and but if your question to me is in terms of patients with acute leukemia or hematologic malignancies, I would say maybe on the average of 5 to 10. But when in patients, hematology,
I think we've lost. No.
Yeah, there's delay.
Yeah. And how do you stay on top of all the new stuff coming out from clinical research? How do you train yourself as a physician to know what's going on? Because it seems like you are doing everything, right? You are doing patient advocacy, and you are a physician, and you are seeing patients. And it seems like you are like a multitasking octopus person. I don't know if you can still. Not sure.
Yeah, now it froze.
Yeah. Now I can hear you.
Yeah.
Maybe close your
maybe
video.
The network from my iPad.
Yeah.
Okay, so maybe okay.
Yeah, that's
okay.
much better. Yeah.
So I hope better now. Okay. All right. So I was saying that yeah, you're right. I do involve in quite a lot, not just advocacy, but also in training and also in medical practice. But part of what we do is we do have continuous medical education programs. We have and access to educational materials provided by the American Society of Hematology through the International Outreach Initiative. And so we are able to get resources even from the annual ASH meeting, even where we're not able to attend physically. We do get a flash drive of the presentations and also have access to the educational materials on the website. So yeah, we do still development. Go along.
Yeah, you do a lot. Very impressive.
Yeah, congratulations, Dr. Adlabo, on all the work you do. I think we have, from your presentation, I think we have similar scenarios, right? So having poor access to information, having patients paying out of their own pocket, many other problems. And I think you summed up well what we need to do, right, to improve these problems and have a better scenario. So like awareness, advocacy, investing in health systems, access to care, which are all very important to keep in mind and keep having these conversations, right, which are very important, and bringing them to our governments, the advocacy and other support groups, promoting online, many other channels, so we can actually improve patients' lives, right?
I agree.
Yeah, I agree. Thank you. So I actually wanted to ask you regarding, you mentioned the training of doctors that you do at Abril. So because part of what I mentioned in that particularly healthcare practitioners in the primary and secondary health facilities, many are also not even aware of some of the things, because part of medical training, they have some degree of knowledge of it, but we find out that having what we're looking at organizing, I wanted to get to know from your experience, what are some of the training modules or training system that you employ? Because you did mention you had trained over 10,000 doctors in your presentation. So I wanted to ask you how you're able to pull that off.
Yes, we do have a distance education project. It's called Oco Ensino, and we record many important information on different types of cancer, not only blood cancers, but prostate cancer, other types of cancers. And we have partnerships with doctors from public systems and private systems as well. And we get in contact with all the health institutions in the country to offer these courses, because doctors do also need to update, right, their knowledge. And that's a very important program. We're very proud of them, of the project. And we also give certificates. We also have Albert Einstein Hospital in this project with us. And we have many positive feedbacks from the doctors that the courses benefit them. And there are many modules they can watch in their own time. So anyway, we have a high rate of completion. So it's a very successful project, and maybe other associations, and not only in Brazil, but I guess worldwide, can also get some inspiration from that.
Yeah, sure. In fact, that's what I was thinking about when you did mention it, because it's something we also thought about, but we've not really decided to, have like a structure, a plan for how we're going to go about that, because we do, think that that would really help in having patients, because most of these patients actually do come as referral from these other centers. So if we're able to train the health workers in those centers, it would help the patients and the loved one. Yes, so perhaps maybe contacting you to maybe get some more information from you, particularly from your experience with this, as we also look into planning similar programs for the health workers or practitioners in Nigeria. Thank you. Yeah.
Right, we can be in touch, of course, and I can provide more information.
Good. Well, I think we are up to the hour now, so
yes, right on time.
right on time, exactly. So thanks to you both for being with us today. It was a very good webinar, so thank you for joining us. And yeah, as I said, I will share the presentation and the recording on the website and also on social media. So if you want also to share with your communities, of course, always feel free to do that. And yeah, let's keep in touch and let's continue raising awareness about leukemia.
Exactly, that's the point.
Yes.
Thank you very much for the invitation. It was a pleasure
Thank you.
to be with Samantha and Dr. Delapre today. See you next time.
See you next time. Thanks a lot
Bye.
and take care. Stay safe.
Yeah, bye.
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 Thank you again.